So our first speaker is Damini Day, who is a local, Cedars-Sinai. She trained in Calgary, I presume, with Richard Frame, and then went on to robots and is now here. And she's very kindly actually recently allowed me to use her Plaque software for some, dare I whisper it, CT evaluation. But I don't think she's going to mention CT too much in a talk about AI in CTA. But here we go. So the first talk of the day in person is going to be on CT at the SMRA.
Thank you very much. Thank you. I thank the organizers for inviting me here to talk about CTA. I have to admit, this is in an SMRA conference. This is a little bit from the other side. So hello from the other side. But the artificial intelligence techniques that have been shown recently in CTA, the techniques are applicable to all images. So they are very general in that sense. And here are my disclosures. So we will talk a little bit generally about machine learning. And as you know, just go quickly through this slide. I don't know if I can have is that like a laser pointer? This is the, okay, yeah. Yeah, okay, good. So talk a little bit about, as you know, artificial intelligence, machine learning, and deep learning. The hope with CTA is that we are starting to get big data because CTA is now, with 64 plus slice CT, has been ongoing since 2004, 2005, and it is almost becoming a first-line test for chest pain. And also, we have a collection of real-world data, which I'll show a little bit of outcomes. And the field, and as you know, the AI techniques perform best with large amounts of data. So where exactly is artificial intelligence in cardiac CT? It is in all phases of the CT acquisition, processing, quantitative analysis, diagnosis, as well as prognostic risk, as you can see here. For example, the vendors have really embraced AI, so there are AI algorithms running behind which will suggest the right protocol to scan the patient based on the scout images, for example, or if the technical parameters, the reconstructions are adjusted so that you get similar CT attenuation for spectral CT. It's very much there in reconstruction and denoising, so we get the best images possible. And then where I have been involved in is more in segmentation and quantitative analysis from CTA to get more information from this coronary CT angiography, and also in diagnosis, decision assistance, and then finally to integrate parameters to predict prognostic risk for the patient. So I thought I'd start with this interesting study. It's a very unique study in many ways because it looked at the changes in healthcare in Medicare only from CMS data from 2010 to 2019. And you can see that this is the prevalence of cardiac imaging for the different modalities, SPECT showing a decrease, PET showing an increase, and CTA as well, and also MRI. But as we know, images are data, and so the first machine learning study which was reported with CTA was actually with visual assessment of CTA, which is the standard assessment of stenosis only. So basically, this is what we do here. We classify different grades of stenosis from CTA in clinical practice, as well also report quantitatively now on other features such as plaque composition and plaque analysis, but it is very much a visual read. So there are 5 grades from no or minimal, grade 1, which is 1 to 25% stenosis, to 25 to 49, and then 3, 50 to 89%, then 70 to 89%, and then finally 90 to 100%, and total occlusion. So these are kind of variations of this grading system is reported for standard assessment of CTA. Here we looked at over 10,000 patients in the CONFIRM registry with 5-year follow-up. And this is a busy side. What was done is an integrative logit boost integration of all the clinical features, which are in green here, as well as CTA features, which are in blue. So you can see that stenosis features were very important in the machine learning model to predict death in these patients, as well as the number of segments with non-calcified plaque and calcified plaque, and the segment involvement score, which in CTA is the number of segments that over the coronary tree that has plaque. So this introduces us very nicely to coronary plaque, which is a very hot topic right now, and CTA allows, because of enhancement of contrast in non-calcified plaque, it allows standardized measurement of non-calcified plaque as well as calcified plaque, which you see here. This is using AutoPlaque software from the Scott Hart multi-center trial. And so at the same time as stenosis assessment, which can be quantitative with plaque assessment software, we can look at low attenuation non-calcified plaque, which is a surrogate of the lipid core, plaque composition, burden, positive remodeling, and also several contrast features, which you see is how the luminal contrast decreases over the vessel. Now, there are several alternatives right now. As I said, this is a very hot topic, and there are several packages available, and this has been nicely summarized by Dr. Michelle Williams in JCCT recently, showing a few of the packages. This is METIS, Clearly, Elucid, AutoPlaque, which is developed at Cedars-Sinai, and SurePlaque, and SingleVia Frontier Coronary as well. So can we actually predict a heart attack using this plaque analysis, was the question asked by Dr. Michelle Williams, and this is in the multi-center Scott Hart trial. This is the landmark trial for CTA. We did a coronary plaque analysis with just the semi-automated software, and it's 1769 patients with about 5 years of follow-up. Here is one example that you see. This patient is a female patient with non-calcified plaque, diffuse non-calcified plaque, and the mid-LAD, low attenuation plaque, which you see in orange here. And this plaque was the reason there was an NSTEMI few years after CTA, that you see here. So in the whole cohort, what we found is that patients with a larger non-calcified, low attenuation non-calcified plaque burden was nearly 5 times more likely to have subsequent myocardial infarction. And this outperformed cardiovascular risk factors, luminal stenosis severity, CT calcium score, as well as the total plaque burden. So it was in terms of plaque characterization, low attenuation non-calcified plaque was carried the most predictive, had the highest prognostic value. So, but that was using semi-automated software. So how can we speed this process? So using standard methods, plaque analysis takes a long time. So we have done work using deep learning, and this has been published in the Lancet Digital Health this year. And it's a large study which had CTA images from 11 sites, 921 patients, 8 scanners and scan protocols. So this is the deep learning algorithm that we used was convolutional LSTM network, and it was trained on these patients. There was external validation from 3 sites, 175 patients, and then we evaluated at the same time the diagnostic performance as well as the prognostic value. For diagnostic performance, we compared to expert readers, intravascular ultrasound, which is pretty much the reference standard for plaque measurements. It's an invasive reference standard. CTA interpretation, and as well as invasive coronary angiography for stenosis grading. And then we looked at the prognostic value again in the Scott-Hart trial. So here's one example of non-calcified plaque that you see in red here and calcified plaque in yellow, segmented by the deep learning algorithm. So there was excellent correlation for deep learning with the expert readers, as well as for invasive intravascular ultrasound, with reasonable correlation for stenosis grading using a CAD-RAD system between deep learning and the expert reader, as well as deep learning and invasive coronary angiography. And this is an on-site analysis. It takes 5 to 6 seconds versus about half an hour by expert readers, and is quite standardized. And then finally, we looked at also the prognostic value in the Scott-Hart trial, which was in our external validation cohort. We looked at total plaque volume, which could discriminate prognostic risk very clearly. Here's 1611 patients in the Scott-Hart trial, and we looked at a cutoff of 238.5 millimeter cubed of total plaque volume. This is from the ROC analysis in the Scott-Hart trial, and we could show that it has a high hazard for predicting heart attack. So and this persisted even when adjusted for obstructive stenosis and a clinical assigned score. So, but plaque volumes are just one measurement. So what we want to do is to holistically predict risk for the patient. So this is one way to do that is to take all the quantitative features and to combine them using machine learning to predict risk for the patient. So we have done this in a separate clinical trial, which is the NXT trial, where patients had coronary CT angiography, and within 1 month they had invasive coronary angiography with invasive FFR. So when we use a logit boost algorithm, which is an ensemble boosting algorithm, we have a high AUC for machine learning, which is higher than the individual plaque components, or quantitative stenosis, or the pretest likelihood of disease. And the interesting thing is that those models can be integrated back into clinical software. So this was integrated back into AutoPlaque software and is an ischemia risk score, which was tested by Dr. Alan Kwan here at Cedars-Sinai. So this is a dual center study where we had 352 patients who had CTA followed by invasive coronary angiography, and over 1,000 vessels. And the question was asked, can this ischemia risk score actually predict revascularization in completely unseen data? So basically here is one example. This is from new data from Cedars-Sinai. And after plaque analysis, what we have is an ischemia risk score, which shows the risk of invasive FFR less than or equal to 0.8 in each of the vessels, as you can see here. In this vessel, invasive FFR was performed, and it was ischemic. And then finally, when we look at the whole dual center study, it's when we add to a clinical model the stenosis and significant stenosis and referral location, we have an increased prediction of revascularization. But which is again increased when the machine learning ischemia risk score is added to the predictive model. So you also know that from CT we can compute CT-FFR from standard CTA. This is typically done using computational fluid dynamics models, but it can also be done by deep learning. So this is evaluation of a prototype software from Siemens, which looked at on-site FFR and a comparison of reduced order computational fluid dynamics with a deep learning model also from Siemens. So this is 5 centers, 351 patients, 525 vessels with CTA and invasive FFR, and here are examples that you can see from this study. So the advantage is that the reduced order computational fluid dynamics is that the machine learning takes very short time, and so the time is even reduced after CTA to get the results. And the results are actually completely equivalent. If you see the AUC, it's 0.84 for CFD-based CTFFR and 0.84 for deep learning-based CTFFR. And both increase prediction of risk over standard CTA. So how can we put this together for the patient? So I want to show an example of explainable machine learning for integrated risk prediction, but this is actually from our work in non-contrast or coronary calcium scoring CT. This has been published in Atherosclerosis recently, where we looked at the coronary calcium score, which is here, and combined with epicardial fat, which is also measured by deep learning, with clinical risk factors and biomarkers to holistically predict risk of prognosis for the patient. So this is using XGBoost models, so one more of the ensemble boosting models. And here you can see the feature importance for a prediction of cardiovascular events in over 1,000 patients in the Eisner trial. This is a long-term follow-up, and here we have age, coronary calcium score, systolic blood pressure, and other imaging features related to the calcium score are very important. For the biomarkers, we had very specialized biomarkers in this population, but LDL is actually right up there. And then finally, when we look at the machine learning risk prediction, it's 0.81 and higher than coronary calcium score, as well as the ASCVD risk score. But what can you actually do for the patient? This is the question we always ask. So we like to think of, it's been proposed that machine learning is a black box, but you can actually open that black box if you have explainable components in your AI algorithm. So this is a little bit of explainability that we can add to XGBoost, where we are looking for a specific patient, what are the weights in the machine learning model that can predict risk for that particular patient. And this can be done at several time points even. But basically, all the patients start from the prevalence of events, which is right here, and we can look at the weights for the clinical factors, the biomarkers, the coronary calcium, and epicardial fat. The red arrow shows that the risk is increasing, and the blue arrow shows that the risk is decreasing, and the risk is high for this patient. So this patient had, in our cohort, had an MI at 8.8 years. So to summarize, models with external validation should be implemented into clinical software and into clinical workflow. Artificial intelligence is a tool, it's not a threat. To the physician, it can eliminate repetitive activities and give you the gift of time. And explainable AI, it's absolutely okay to demand explainable AI from the AI models that you're using, because it can open the black box and explain the rationale. And then finally, it can allow us to do new things. It can measure what is measurable and make measurable what is not so, as put best by Galileo Galilei. Thank you very much.